Hi, and welcome back to the Mom and Mind podcast. I'm your host, Dr. Kat. On this episode, I am talking with Dr. Katrina Furey. She's a board certified adult psychiatrist specializing in women's mental health and reproductive psychiatry. In our episode, we are diving into understanding a bit about how hormones impact our mental health, very specifically in the perinatal period, but also at other times in the life cycle of a woman. And we're also going to touch a bit on birth control and how that might impact our mood as well. Dr. Furey is also a clinical instructor in the Yale University School of Medicine Department of Psychiatry. She also has a private practice, Sound Psychiatry, in Guilford, Connecticut. She's consulted for Connecticut's Access Mental Health for Moms hotline, offering psychiatric expertise and consultation to medical providers treating women for mental health or substance abuse conditions. She also co-hosts a podcast called Analyze Scripts that analyzes the depiction of mental health in fictional television shows and film, which is just such a brilliant idea and so entertaining because, as we know, sometimes they get it wrong, but sometimes they get it right. And in October of 2024, Dr. Furey will be launching a Repro Psych Academy, which is a comprehensive series of online courses designed to empower all healthcare providers to feel more confident in diagnosing and managing women's mental health conditions related to hormonal shifts from menses to menopause. And I know people often have questions about how really do our hormones impact us? And we'll hear a little bit about how they do. So I'm excited to jump in and talk with Dr. Katrina Furey. Welcome, Dr. Furey. Thank you so much for being here.
Thank you so much for having me.
Um, I'm really excited that we got to meet at the PSI conference in person, and it's so nice to do that, especially in this world of social media. And I get to see
Mhm.
all the cool things you're doing, but to actually meet you, your energy is just lovely, and
Oh,
it was such a treat. And now we get to do this and have a nice long
yes.
convo about stuff that you love and I love and what could be better.
Yeah. I know that was so fun about the conference is I feel like
Mhm.
I got to meet all these people I feel like I know
Mhm.
already, mostly
Mhm.
from social media or like, consuming their content online.
Mhm.
So that was really cool.
Yeah, it's fun. So, yeah, we're all passionate for a reason, maybe multiple reasons around this specialty. So how about for you? What's your personal connection?
To women's mental health.
Yeah, yeah.
Well, so I w I mean, I'm a woman, first of all, I'm a mother, okay,
Mhm.
so that is natural. I would say, I wasn't the kind of kid who grew up dreaming of being a doctor. I don't have any doctors in my family. I come from a family of artists. Both of my parents were musicians. My grandma
Oh,
was a musician. I grew up dancing. I thought I'm going to be a rockette
how
or be
fun.
like a backup dancer for Britney Spears or something. That was my goal, right? And then sadly, my dad got sick when I was a very young child, and we didn't know
Mm,
what was going on for a long time. And it came out later that he was suffering with Alzheimer's dementia.
mm,
And that really just shifted my perspective in a lot of ways at a pretty young age. And so in college, I switched gears from pursuing communications to medicine or pre
mm,
med.
mhm,
And then I ended up going to Boston University for med school, thinking I'd go into neurology,
mhm.
thinking I wanted to help people like my dad. And then I was totally shocked when I fell in love with my OBGYN rotation. Just totally came out of nowhere, but I
Mm,
loved it. I didn't
mhm,
love the lifestyle. And then I got to psychiatry and I thought, ah, here it is. We
mhm,
got the neurology side of things, we have the therapy side of things, which I
mhm,
love to practice in my practice. And then once I got into residency at Yale and went through my different rotations and trainings, I realized not till later on, till after having my own kids, having my own struggles with things like postpartum depression and anxiety
mhm,
and miscarriage and all of that during my training, that there's this field of reproductive psychiatry that
mhm,
barely anyone knows about. We
mhm,
barely talk about it. The
mhm,
the ACGME, actually, the accreditation body that oversees all the residency programs, they don't require that any of them teach anything
mm.
about women's mental health or repro
Wow.
psych, which I think is
Um,
shocking,
yeah, but also not
but also
surprising.
not, right? I know, right?
Shocking, but not surprising.
Shocking, but not when you think about it,
Uh-huh.
right?
Yeah, yeah, yeah.
So I sought out a lot of, individual case conferences, individual supervision and stuff like that, to sort of learn as
Mm,
much as I could. And then as
mhm,
I've gotten into my own private practice, I've developed a nice niche in women's mental health, treating patients, with everything from PMDD all the way through perimenopause. And I have a big chunk in the perinatal years. So I do a
mhm,
lot of work, before, during, and after pregnancy. And I just love it.
mhm,
I think
mhm.
it's such a ripe time, both for intervention from a
Yeah,
mental health perspective and to see treatment work, both in
totally.
terms of medication, but as well as therapy. And I feel like you can really feel like you're making a big difference for the patient in front of you, as well as their family system,
Mhm.
healing old childhood wounds. I feel like it's the best. It's the best.
Yeah. Yeah, it really is. Well, that is an interesting path. Like you
Yeah.
wound your way to
Weaving
it.
and winding. Yeah.
Yeah, as is true for so many of us.
Yeah.
So being in this specialty now, I mean, I would just want to go back to what you said before about not people not really knowing that reproductive psychiatry is a specialty.
Mhm.
Um, that's in general, but also is that true that people don't really know about it within the field of psychiatry
Yes.
within uh-huh.
Isn't
Yeah.
that nuts?
Mm,
Yeah, totally. I mean, I still maybe will always get inquiries from other providers in the community, whether it's other psychiatrists, therapists, pediatricians,
mhm,
internal medicine doctors. Once they figure out who I am or what my specialty is, they, oh, well, that's really interesting. I bet there's a
mm,
lot going on there. And I'm like, yeah,
yeah.
turns out there is, right? But
Like
again, I
a
think it
lot.
a lot. I always say that our understanding of women's health, let alone women's mental health, it's like
Mhm.
we're crawling out of a dark cave
Yeah.
where like pregnant women just haven't been included in studies forever,
Right.
right? It's
Yeah.
hard to do, the gold standard randomized controlled trials on pregnant women.
Mhm.
And yet we know this is a big deal. This happens to a lot of us, and,
Mhm.
treatment works, and we need to get the word out.
Absolutely. So it's so important that people know that repro psych is a specialty, especially because I mean I'm sure you hear stories all the time of what can happen if somebody who is in the perinatal period and goes to a psychiatrist and doesn't
Mhm,
get the kind of help that they need
mhm.
potentially because like not that the psychiatrist is a bad psychiatrist but they just don't have the training in what
Right.
to see or to recognize and
Mhm.
can you speak a little bit of that like to that importance.
Definitely. Oh, definitely. I think too because the the I guess the recommendations over the years have evolved.
Mm,
So maybe 30 years ago, we or, doctors would recommend, if you're on Zoloft before you get pregnant, maybe you should stop and just try to hold on,
mm,
till the baby gets here. Just try to manage with all your
mm,
other coping skills. But now we know actually that's not a good idea.
mhm,
Now we have plenty of evidence that shows that all the risks that we were worried about being attributable to the medication, we actually see related to an untreated depression or anxiety. So it's probably that's
mm,
causing, the outcomes like, preterm delivery or other types of complications rather than the medicine itself. So the advice has changed over the years. And if you don't keep up
mhm,
with it, you wouldn't know it. So you're sort of stuck giving old advice, I guess, is what
mhm,
I, usually tell my patients who come to see me
mhm,
after maybe their current provider told them to stop their meds and now
mhm,
they're really not doing well. And we have to have a hard conversation. Sometimes to other specialties like OBGYNs, their focus is a little different than mine. They're
mhm.
focused on the baby, getting the baby here healthy, mom's physical health. I love when I find OBGYNs who are on top of it when it comes
Yeah,
to mental health and they want
yeah.
to collaborate. That's the best. But again, they don't get, if psychiatrists don't get the training, if it's not
Mhm,
required, like I'm pretty sure it's not required for OBGYNs, right? To
mhm,
like get all this
mhm,
training about perinatal mental health. So, my focus is different. This is my area that I keep up with and I love. And so it is so important that you're, seeing a provider who is up to date with the latest, recommendations and things like that so that you're in good hands. I think, unfortunately, there's not enough psychiatrists, period, let
mhm,
alone
mhm,
reproductive psychiatrists. Since it isn't a formal fellowship program yet or doesn't have any formal training, it can be hard to find, certain providers like that, but not impossible.
mhm. Right. So there's a lot, like you were saying, there's a lot that hasn't been studied about women in general, women's health in general, women's mental
Mhm.
health very specifically. It
Mhm.
just, it just, it's more and more known that lots of studies were done with men for a lot of different things,
Yes.
like most conditions.
I actually was reading in a textbook just last week, and I had to laugh and
Mm.
then maybe cry, that they said, like, the way like, literally I wish I had the quote in front of me. It was something like, "The way that they used to control for the unknown variable of pregnancy was to just exclude women from all the studies." And I was like, "Well,
Mm,
huh, how
mm.
about that?
How
How
about that?
about that?
Wow,
Oh,
and then apply those findings to people who
to
are not in
women."
the study. Yeah,
Yeah,
it's wild,
100%.
wild.
It's
Okay,
wild.
so we're getting better, little by little, maybe. But there's so within that, there's this huge component of women and hormones.
Yes.
Our hormones are barely being understood.
Yes.
I assume there's a bit more on men, research on men, but
Yes.
so, and then research in perinatal mental health and hormones and all. So
Mhm.
people have a lot of questions about hormones
Yes.
and what's
Yes.
involved and how much is the hormonal stuff a part of what happens with things like depression and anxiety.
Yes, I love talking about this because I just don't understand why, as women and girls growing up, like, we're really not told about this stuff.
Mm-hmm.
You sort of are, like, about your periods, but none of us really know, like, what's
Mm-hmm.
actually going on. Like, what are the
Right.
hormones going up and down, and why am I feeling this way?
Mm-hmm.
And it turns out it's not all in our heads,
Oh,
okay? Like,
yeah.
we have a lot of research
Mm-hmm.
now. You're right that most
Mm-hmm.
of the research has been done in men, and that was easy because men's hormonal levels pretty much stay steady over the course of their life. They're not
Mm-hmm.
fluctuating monthly.
Mm-hmm.
Yeah, they go through puberty, but then there's levels stay steady. Whereas for women, we have monthly fluctuations if we have regular cycles. We have periods where those fluctuations stop and things totally shift if you're
Mm-hmm.
getting pregnant.
Right.
Then we have you sort of resume, hopefully, regular cycles, and then you go through perimenopause, which can last between 5 to 10 years. And then you're in menopause. And so the hormonal, landscape that you're ending your life with is totally different from how you start your life. And
Mm-hmm.
there's a lot of fluctuations up and down in between. And so, one of my favorite things to do to talk about with my patients is, what science do we have that I can tell you about to help you feel reassured that it's really not you? Like, it's really not all in your head.
Yeah.
You're not the exception. Like, this is really common. And for some reason, we just don't talk about it enough.
Mm-hmm.
So, starting with things like our periods, like, we've come to find that it really is the fluctuations in the hormone levels, specifically estrogen and progesterone. But there are some other hormones that are important, like FSH, which stands for follicular stimulating hormone, LH, which stands for luteinizing hormone. That is the hormone that surges right before you ovulate. That is what the at home ovulation kits are testing.
Mm-hmm.
And then there's some other hormones that we don't have to get into. But really, it's the fluctuation in the estrogen and particularly the progesterone that's really important, because progesterone, if you look at the metabolic pathway, gets metabolized into all these different metabolites. But one of them turns out is really important. It's called allopregnenolone. And that is like the golden hormone for right now. That's the one that studies over the past maybe 20 years have shown there seem to be differences in that hormonal level in women who do not have postpartum depression versus women who do.
Mm-hmm.
And whether it's the level in the hormone in your blood or in your cerebrospinal fluid, like with the spinal tap, or there's even some studies showing that women might have the same levels, but their receptors don't seem to be quite as sensitive to it. They're not responding to it in the way that
Interesting.
other women do.
Mm-hmm.
And it turns out that's the same hormone that's implicated in premenstrual dysphoric disorder,
Mm.
which again is a real thing. This is a
Yes, it
biological
is.
condition. We have treatment for it, but it's not the same thing as PMS or what we call premenstrual exacerbation of a primary mental health condition like
Right.
depression,
Mhm.
bipolar,
Mhm.
OCD, psychosis. All of those conditions, for the most part, even ADHD, can show premenstrual exacerbation. So it's really clear there's some sort of interplay, some sort of interaction. And then when we sort of zoom out, we have to think that, humans are complex And
Mhm.
not everyone's going to respond to these fluctuations the same way. So we're really,
Right.
we as in, the medical field, the researchers are really trying to, figure out who's at risk for this and how can we
Mhm.
help. And I think that's where what I'm super excited about being in this field now at this phase and at my age, at the relative, in the early part of my career
Mhm.
is, gosh, I really hope by the time, 30 years down the road, we know so much more. And it's really exciting that, they're coming out with medications like brexanolone, zuranolone, which are allopregnanolone synthetic analogs
Mhm.
that until now they haven't been able to develop these compounds in a way that women could take it and not get overly sedated. So
Oh,
that's still like
right,
the
right, right.
biggest risk.
Mhm.
But like with the IV infusion, the brexanolone, that's why you have to be admitted because it can be
Mhm.
pretty
Mhm.
sedating.
Mhm.
The oral medication, the first FDA approved medicine
Mhm.
for postpartum depression, that is so exciting,
Mhm.
is a synthetic version of that compound allopregnanolone. So that's really exciting. And again, it just goes to show like there are biological reasons a
Yeah.
lot of women feel like this. And I think just knowing that helps so many of my patients feel less alone and
Mhm.
feel less at fault.
Mhm.
It
Oh,
helps you really
yeah.
remove that personal like it's my fault this is
Mhm.
happening.
Mhm. Thank you for that. That is super helpful.
It's so cool.
And unfortunately, I think we have, well, historically, anyways, this been dismissed as being quote unquote just hormonal.
Yeah,
Uh,
right? It's like, sorry to
mhm.
interrupt you,
No,
but doesn't
go
it
go
drive you
off.
nuts?
Yeah. Yes.
Doesn't it drive you nuts that on the one hand, everything will be dismissed as it's just your hormones,
Uh
and
huh.
then on the other hand, there's no grace given for these
Right.
hormones, right?
Right.
Like, you're just expected to, like, go to work, you feel like your stomach's, like,
Mhm.
exploding inside.
Mhm.
You go back to work, at least in America, after such little time,
Right.
it's like you can't win.
No. Like you're sort of judged for what your body is doing, as if you have
Right,
some choice or some
right,
control over it, or that you should
right,
just be able to deal. And
right.
it's such an unfair pressure that's put on.
I
I
totally
mean,
agree.
if I get real snippy and flip the script a little bit, like if dudes or people
Ugh,
were to go through any of this,
anything.
things would be very different.
I mean, yeah, there is, like, a reason why the man cold is a joke that we
Mhm,
all relate to. Can you
mhm,
imagine if it was more than a cold that happened every month?
mhm. Oh, it's a lot. It's a huge amount that the female body goes through so often, so often.
So often.
And anybody who has like a regular period.
Mhm.
There's this a weird thing that happens like every month. I'm gonna just speak for myself. I'm in perimenopause right now, but when I had regular periods, be like, wait, like what is happening? Why do I feel this way?
Yes.
And then like it's almost like period amnesia or something. Like
Yes.
just forget that the
Yes.
same thing happens every month, and then period starts, and you're like, oh, okay,
That's why.
that's why I
Yes.
felt like that.
This is
Um,
yeah, this is one reason why I'm, like, late to the game with
mm,
Instagram and stuff because I
mm,
think I was in, like, training, then having kids, I was, like,
mhm,
living under a rock, and now I'm like, "What is this world?" But there's some really funny reels out there
mhm,
about that very thing. I saw one
mm,
yesterday and just cracks me up.
mhm. It's a real thing.
It
Um,
is.
but um, well, connected to that, and thinking about hormones and how it's all connected, I know that PMS in particular and PMDD is a risk factor for
Mhm.
perinatal mental health conditions or pregnancy or
Mhm.
postpartum. Is it kind of as you understand it, or based on what we know now, what is known now, is it the same thing that's causing, like if you're have PMS or PMDD and you're at
Mhm.
risk of having postpartum depression, is it because of those same hormone fluctuations, like a sensitivity
That's a
to
good
that
question.
hormonal
Yeah.
change?
So that is one hypothesis is that if you are a woman who has an underlying maybe genetic predisposition
Hmm.
to, either not respond to those fluctuations in a typical way, or maybe your receptors aren't quite as sensitive or something like that, the signaling's a little off,
Mm-hmm.
then like if you notice that with PMDD, that could very well happen in the perinatal and postpartum period. Um, Interestingly, in perimenopause, we also see that. Like, if you have experienced PMDD or any perinatal mental health issue, then you're at higher risk for experiencing a similar issue in perimenopause. And perimenopause is also a time period in a woman's life where the incidence of first depressive episodes and first psychotic episodes for schizophrenia and first manic episodes can come out. So you could live your whole life and not experience that. And then during perimenopause, there's like this second peak that we see for a lot of mental health conditions. We don't see that in men. So again, earlier in our lives, women and men tend to develop that first episode of whatever it is
Mm-hmm.
around the same age, women
Mm-hmm.
a little later, but most of the time, your late teens, early 20s, early 30s. That time period coincides with women's peak reproductive years. So for a while, and I think some people still want to keep in mind, like it could also be that you're experiencing this first episode and it happens to be during this time period when you're
Mm-hmm.
getting pregnant and having children. And again, what I hypothesize is 30 years down the road, I bet, I hope, I pray to God we
Mm-hmm.
have a better understanding of what's going on for women. And I bet there's different subtypes of like what is postpartum depression? Is
Sure.
it major depressive disorder that flares up in this period?
Mm-hmm.
I think that's probably one subtype. And is there another distinct subtype that's related to these hormonal fluctuations? I
Mm-hmm.
think so. And I wouldn't be
Mm-hmm.
surprised if there might be even more.
Mm-hmm.
But again, like if you take the hormonal piece out of it, um, pregnancy is really stressful. And we know that like life stressors and transitions and all those things are also risk factors for
Mm-hmm.
depression, anxiety, OCD, things like that. So I think there's a lot of stuff going on. But yes, if you have had PMDD in the past, you're at higher risk. That doesn't mean it's a slam dunk. That doesn't mean it's going to happen,
Sure.
but it's good to know about, right?
Mm-hmm.
Um, and it's just an interesting, thing to keep in mind and a place you can intervene.
Sure. Okay, that's helpful, especially for people who are already know that they have that hormonal shift sensitivity with PMS
Mm-hmm.
or PMDD to look out if
Mm-hmm.
they're going into trying to be pregnant and have a baby. That's something to really keep
To
tabs
keep in
on.
mind. And
Yeah.
also, I will also say, at least in my practice, also see sort of new onset, I'm putting that in quotations, PMDD after people have had their children. I think that our periods just change. Like, I don't really
Hmm.
think your system goes back to what it was. I think it just like
Hmm.
recalibrates, and there's like a
Hmm.
new system now that we're dealing with, right?
Hmm.
Like, I don't really think we ever go back,
So
right? We
fun.
just keep moving forward.
Hmm.
But, I see this a lot where women tell me, like, "My period has really changed, like, the
Hmm.
flow, the
Hmm.
heaviness, the
Hmm.
length of time, like, it's different." Sometimes better,
Hmm.
that's very lucky if that happens, but other times it might be a little worse, or and maybe it's just the patient population I see, maybe now they know what a depression or an anxiety episode
Hmm.
feels like, so now they're recognizing
Mm,
it, and then
more
when you
aware.
trace it back, maybe they have been living with that their whole life, it's just we don't talk about it enough,
Yeah, no kidding. I do see that a lot. People,
right?
right. It couldn't feel like it's the first time you're experiencing this, but it's very common to realize that there's been anxiety the whole time or depressive episodes. But
Right.
yeah, exactly what you're saying. We don't talk about mental health enough.
Mhm.
And with you kids that are growing up to be able
Right.
for them to recognize what's happening, let alone
Mhm.
parents and so on and so forth.
Right.
Um, so is there do you know, or is there research, is there any information on understanding the hormonal shift differences between different conditions like depression or anxiety or bipolar or psychosis, or is that just like there's just no info yet?
I think there is info. I think it's just still it depends. Like, I think
Hmm.
we have a lot more info for depression, for example, than we
Yeah, yeah,
do
for
for
sure.
other conditions. Um, the question about psychosis, I think, is really interesting, and something that I'm just like trying to keep up with because there's so much research about what causes psychosis. I think it's a condition, understandably, I think most people are scared to experience. And there does seem to be some sort of link to estrogen. I was just reading about the estrogen hypothesis of schizophrenia, which again, in the first, between the ages of 20 to 50, men have a higher incidence of schizophrenia, and then it switches once you go through the perimenopause period. So after 50, women actually have a higher incidence, and it's presumed to be due to that estrogen decline that
Mm-hmm.
comes from perimenopause. And so again, women can have their first psychotic episode after menopause, whereas that doesn't really happen for men.
Mhm. Mhm.
So I think there's just so much more we need to uncover and understand
Right.
better. But it is exciting that people are finally looking into it. And I
Yeah.
think even the area of like ADHD, for example, is
Mm.
another area I'm really interested in. It does seem like there's a link between the hormonal shifts and even ADHD, which you might not think about just,
Mhm.
on the surface. Again, I tend to see women who it's like they've kind of coped with it their whole life, but never got
Mhm.
diagnosed.
Yeah.
And now you add kids, now you add a career, you add
Mhm.
caring for your aging parents, and then you
Yeah.
add 10 years of hot flashes. And it's like, okay, I
Right.
can't cope anymore. Like, okay,
Right.
this exceeds my ability to
Yeah.
cope. So
Yep.
yeah, I mean, there is research out there, but I hope we get more and more as time goes on.
Yeah. Yeah, I have been seeing a lot. I mean, I haven't really read into research on it, but just anecdotally hearing a lot about ADHD symptoms
Yeah.
exacerbating perimenopause, but and also for sure in postpartum. I mean, I have
Oh,
talked
for
to
sure.
some folks on the podcast who realized they were dealing with ADHD after going through postpartum and
Hmm.
seeing their kids have
Yes,
symptoms,
when
their
your
kids
kids get
getting
diagnosed and you're like,
oh,
huh,
wait a minute, might
wait a
be me.
second, I do that too. Yeah, exactly.
Right, right. So yeah, we still have a long way to go.
Yeah, so I mean, one question I get a lot from my patients is if I take birth control, or I hear when I took birth control,
Mm,
it like really messed up my mood. And so I always like to talk about this. And again, I think this is one of those areas of medicine that I hope we keep investigating and our understanding will improve over time. But as the studies show right now, most forms of birth control, if you aren't sensitive to these fluctuations, don't affect your mood. You should be fine. Maybe when you're first starting it and your body's adjusting to it, you might notice some things, but it shouldn't precipitate a depressive episode, an anxiety episode, things like that. What's interesting is that a lot of the combined hormonal contraceptives, like the pill, the NuvaRing, other things like that, that have estrogen and progesterone, most of them have a version of synthetic progesterone that acts more what we say androgenic in the body.
mm.
So, androgens are the class of hormones that include testosterone, the things like anabolic steroids that people might take to beef up. You might be able to keep in mind that when you do too much of that, you get like roid rage, right? Like
Oh,
that's what we
right,
call it,
right,
right? Like
right.
you get like irritable and you're yelling at everyone, you're a hothead
Mhm,
and stuff like
mhm.
that. Or when you got a lot of testosterone, you're like very manly, right? Like that's what you do. So for women who are sensitive to these shifts, um, if you take a type of birth control that has one of these synthetic versions of progesterone, there's a chance you might have that like a reaction like that. It might make you a little more irritable,
Mhm.
a little more anxious, a little more revved up, and you might have some mood lability. So if you notice that, the type of birth control we recommend, especially if you have PMDD that's been confirmed with a good evaluation and tracking and things like that, is the one that's called Yaz, which has the component drospirenone in it. And again, just aside, this isn't any medical advice. Please talk to your own doctor.
Mhm, mhm.
But to just get the word out, again, I just love telling women it's not all in your head. Like we have science to
Yeah.
back this up. And so that one is the drospirenone is the one that's most like natural progesterone and allopregnanolone. That's why it's the
Mm,
one that tends to work. But even still, with that, there are a subset of patients, a very small percent, that have like these paradoxical reactions. Whereas progesterone is usually sedating and an anxiolytic, which means it improves your anxiety. That's why, again, it's been a long time coming that we've been able to, pharma has been able
mhm,
to create compounds that aren't overly sedating. In
mm,
a small subset of people, it can do the opposite, where it makes you irritated and
mhm,
aggravated and stuff like
mhm.
that. So I think that's a really interesting thing to keep in mind because often when women have PMDD or they're struggling with their periods, whether it's for reasons like PCOS or they have really heavy flow or something, birth
Right.
control is often one of the recommendations. And I see a lot of people really nervous
Yeah.
about how that's going to affect their mood.
Yeah, absolutely. I mean, I think that's really, really important, the discussion about birth control, because even for people who are uh, wanting to, even for people who are on IVF, like
Oh,
sometimes
yeah.
birth control is often
Yep.
used to
Hmm.
manage their cycle.
100%. Yeah.
There's like high sensitivities there. Then if you're in between, like just having a baby and maybe trying for the next, you might be
Mhm.
using a birth control.
Mhm.
So, like that understanding, if you already have a sensitivity to it, that
Mhm.
it could be exacerbating, potentially exacerbating.
Potentially. Right, but that
Um,
for most people it doesn't. Like
mhm,
from what we can see for the vast majority, it doesn't tend to affect your mood. But sometimes it does. And again,
mhm,
that's okay. But it's helpful to think about that sort of reaction. Okay, is there a broader context? Is there a reason why you're responding in this way when most people don't? Like, is that the first sort of inkling
mhm.
that is there something going on we should pay more attention to?
Well, for sure, especially, and if what you have been saying is, if if you can not blame yourself for something, then that's
Yeah.
all the better. Which is what we tend to do anyways. Like, what's wrong with me? Why
Yeah.
am I should all of this stuff. But maybe there's something hormonally
Yeah.
happening, physiological happening. You're responding to something, and so maybe check those out first before blaming yourself.
Right.
Maybe.
And I don't think, sadly, I don't think the medical system at large helps us not blame ourselves, like we barely focus on women's health, let
Mhm.
alone women's mental health. And
Yeah.
the training is so scant as it is that, I always just tell people trust your gut, trust your
Mhm.
intuition. Like,
Mhm.
your body the best.
Mhm.
And even all the research I'm citing, it is just research. Like, not everyone fits in nicely to these diagnostic categories or things like that. And that's okay. Like, what's
Right.
most important is just being attuned to what you're going through and trying to figure out, like, is there a way to help you feel better? Sometimes that involves medications. A lot of times it involves a lot of other stuff too,
Mhm.
whether it's therapy or regulating
Mhm.
your sleep,
Yes.
exercise, all of
Yes.
that stuff. It's all works together.
So I've heard of some kind of tests that people can take or doctors can give to help their patients know which medications would potentially be best for them.
Hmm.
And I don't know a whole lot about this. So
Hmm.
can you speak to that?
I would love to. I would also love to say that I would love to have the PR representation that those tests have because
Okay. There's our
they
first clue.
there we go. They have a lot of good PR, but the message has been a marketing I think it's been used for marketing tactics. So what these tests look at is they look at the rate at which you metabolize certain medications. So a lot of the medications we give to people are metabolized through your liver and they involve a set of enzymes that we call the CYP enzymes. It stands for cytochrome P450. That's like the enzyme clusters and then there's all different enzymes, okay? And so what these genetic tests do is they look at like how good are those enzymes working for you? And so what annoys me about this is that thus far, we don't have any clinical data that says, okay, so if your enzyme is working at this rate, does that mean the medicine's going to work better for you or not? We don't know. There's no
Mm,
like clinical correlation here.
okay.
Um, it might be able to tell you if you're giving someone the typical dose of medication and they seem to be burning through it, like it's just
Mm,
not holding them.
mm.
Then I think it could be interesting to see are they a rapid metabolizer? If so, then you might need to go up on a higher
Oh,
dose.
interesting.
Your
Okay.
insurance company might then listen to you, like, when they send you the prior auth because they won't approve it, and if you give this data that shows, like, they do need this higher dose, then maybe they'll approve it. Like, in situations like that, I think it could be helpful. Where I
Mhm.
think it's misleading is that the marketing message everyone gets is that it will tell you which medicine works for you.
Mhm.
And it doesn't have that direct clinical correlation, and
Mhm.
unfortunately, the medicine that's always in the green, these results come as, like, red, yellow, green, like, hard stop, don't take these, yellow, like, maybe, and then green, these are the ones that'll, quote, unquote, "work for you." The ones that always show up are Prestique, and there's another one that are metabolized by the kidneys. So, of course, it's gonna show up as that's the one that's gonna work because it's not testing. There's
Sure.
no liver metabolite that
Oh,
it's looking at. So, I just think these it can be very misleading. Um,
fascinating.
and I think people will, like, order it and then start Prestique is the one I see all the time, or
Mhm.
another medicine because it's in the green, but really you don't have to.
Right.
So
And that's
that's
not
why I
that that medication is neither good nor bad. It's just that it's being labeled as like you can take this
and it should work,
and it
right?
should
So
work.
again, like, what if it doesn't? Then are you gonna like, does that add into the shame you already feel? Or
Yeah.
I think it could get really complicated. And again, you might like Prestique isn't, or whatever the medicine is, you might jump to one that we don't often use as a first line treatment because you think, oh, those first line treatments won't work, but we don't really know until you try it.
Mm,
So again, I think there's hope there. I just think it's
mhm.
really being marketed in a way that's a bit misleading.
Fascinating. I know.
I
I guess everything's a business. Uh,
know, right?
yeah, that's tough. So you had briefly mentioned something I want to come back to is that like when a medication doesn't work,
Mhm.
let's say somebody is started on whatever letter A medication and they
Mhm.
try it for 4 to 8 weeks and it's just not working. How do you
Mhm.
talk to people about that? What is how often do you see that like the
Mhm.
first time medications aren't the right ones?
Mhm. I would say that the way I approach it with patients, excuse me, is I always just mention that, when you're starting a medication like an antidepressant, that's the one that we recommend it can take 4 to 8 weeks for it to fully kick in. Again, because it not only, SSRIs increase the amount of serotonin floating around in your brain, but then they prime your receptors to like gobble it up and they think, oh, that feels really good. I feel a lot
Mhm.
better with this. So then you grow more receptors. How
Mhm.
cool is that?
Mhm.
But it takes a while for your brain to grow receptors, right?
Mm.
That's why it takes that long. So I always just tell people that so they know, why do I have to take this for so long? I tell them this isn't like taking an antibiotic. However, the new FDA approved medication kind of is. You only have to take it
Oh.
for like 2 weeks, which is so cool. Um, just to get them, on board that this takes a little while. We're attempting to alter your brain chemistry. So you might experience some early side effects, those should go away. And even though you won't experience the full benefit for 6 to 8 weeks down the road, within 2 to 4 weeks, we want to see some positive shift. That's what I'm looking for, is some positive shift. And some patients can really put their finger on it. They're like, oh, my appetite's back.
Mm.
Oh, I can finally go to sleep and I'm not up ruminating all night.
Mhm.
Others can't, they're not that specific, but they're like, I just feel a little lighter. Just
Mhm.
feel like the fog is lifting. And that's when I say, great, we're going to stick with this medicine. If within the first 2 to 4 weeks you're not so much getting that, that's when I think, okay, let's shift gears. Like if you're not noticing anything, I'm
Mhm.
not going to wait another month. Let's shift gears and try
Mhm.
something else or
Mhm.
things like that. It's not uncommon to have a couple of medication trials. But in my experience, the trials are more successful when you have good education up front about what the patient can expect
Mm.
and what to look out for in terms of early side effects. So you reassure them. Like if you feel a little anxious at first, if you feel a little revved up and you're on Prozac, for example, like it should go away. There's
Mm.
other stuff you could take in the meantime to help mitigate those feelings. That would be short term, and that's a sign your brain's responding. And so
Mhm.
like that's sort of good, but we want you to be comfortable in the meantime. Or we
Mhm.
might lower the dose a little bit to make it more tolerable. There's things you can do, and in my experience, the more you can educate people up front, the more they know what to expect, then the easier it is to kind of like sit with any of those early side effects.
Mm. Mhm.
But yeah, if you
Yeah,
don't respond right away, that's okay, and there's other medications you can try.
sure. So I've only run into a couple of people who tried many
Mhm.
trials of a medication only to find out later that there was something else going on
Mm,
that was like um that the medications weren't working for some reason. Like for
mm,
one person, she found out she had the MTHFR gene
mhm,
mutation and wasn't
mhm,
metabolizing a lot of things the right way.
mm,
But I
mhm,
assume that there are both known and unknown reasons why that it sounds rare. I think it's rare
mhm.
that
I
that
hope so,
happens.
yeah.
Yeah. Rare that multiple trials don't work. But I it they that has to happen where there's something
Mhm.
else that's impacting
Yeah.
the efficacy of the medication.
That's why it's also so important from the start to get a good quality evaluation
Mhm.
where you see someone like me who's thinking also, what are the other medical issues we need to rule out
Yeah.
before we start medicine, right? Like, especially in women of childbearing age, you got to check a thyroid. You want to
Mhm.
make sure they don't have anemia. I
Mhm.
have a whole slew of labs I always check up front and I tell my patients, odds are this is depression, like,
Mhm.
odds are,
Mhm.
and I'm gonna check all this other stuff
Right.
because if it's a thyroid disease, the medicine's not gonna work. We gotta refer you to endocrinology. If it's a mild vitamin deficiency, cool. You still probably have depression, and we're going to supplement because your brain needs vitamins, right?
Right,
Like
right.
all these other things also have to be working in concert to feel your best. But that's why it's so important to get a good evaluation, especially as women with our fluctuating hormones and going through
Mhm,
all these different phases and stages of our lives, like things can happen.
mhm,
And so, yeah, if stuff isn't working, certainly like listen to your gut, and make sure you're getting a good quality evaluation that also includes the physical signs of
mhm,
certain things. And some hormones, hormonal fluctuations do affect the efficacy of medication, like
mhm,
estrogen. When estrogen levels are higher, it increases the rate at which lamotrigine is metabolized. And so I often see people who are taking lamotrigine or Lamictal and also on a birth control, but they have that week of free, that pill-free week, right?
mhm, mhm,
And then so their Lamictal level the whole month is actually different because of the
mhm.
estrogen levels going up and down. And if you aren't in the hands of someone who knows that and is adjusting your dose appropriately during the month, your symptoms aren't going to be stable. And then the same thing when you get pregnant, as your
Interesting.
estrogen goes sky high, it can affect the rate at which you metabolize your medicine. You're going to need more. So,
Mhm.
yeah, all of that's really important to keep in mind.
So, I mean, okay, we need more reproductive psychiatrists,
Yeah,
clearly.
right?
Like, what you're
And it's
talking
also
about
like so cool.
is not something that it sounds like all psychiatrists, maybe, have training in.
Because we're not required to. Isn't that nuts?
Yeah.
Just nuts.
Okay. Whoever powers that be,
You're
make it required.
ACGME, yeah.
Just do it.
Right, because you think at least 50% of your patients, no matter where you work,
Mhm.
are gonna be women,
Mm,
right? Like, even if
right.
they're fine, they're
Yeah.
still experiencing all this stuff all the time.
Yeah. Okay. So we need more people trained.
Yes,
So I know you're trying to tackle this problem as
yes,
well. Can you
yes,
speak a little bit to what you're doing?
100%. So I, had this awesome idea, crazy idea, whatever, that I am getting frustrated that not
Mm,
more women who I'm seeing don't know anything about these hormonal fluctuations they're going through. A lot of providers feel really uncomfortable managing pregnant women and their mental health. And it's like the number one complication of pregnancy. So we
mhm.
really need everyone to feel more comfortable with this. And I just think that people could do it if they had the right training, right? Like
Yeah.
it's a skill you learn, it's a skill you practice. The more you do it, the more comfortable you get. And again, it's so rewarding to help women over the course of their lives, especially in the perinatal time frame, that I just think if people felt more comfortable and knew what to do, they would love it as much as I do.
Mhm.
And so I have decided to launch my first online series of courses called Repro Psych Academy that is targeting other healthcare providers like
Mm,
general psychiatrists,
mm,
OBGYNs,
mm,
primary care physicians, therapists, APRNs, PAs, anyone, lactation consultants, come one, come all, anyone
mhm.
who works with women and wants to know more about the different mental health conditions and how to treat that. Come on. That's where I can teach you all of this. I will be your encyclopedia.
Mhm,
I love
mhm,
keeping up to date with all this, the nerdy science, and I love telling it to people because it's
mhm,
so cool. So I'm launching my first series of courses, the Foundations Pathway, in October 2024. And then in November 2024, the Proficiency Pathway will launch, and then the Advanced Pathway in January of 2025. And then once I get these courses out for professionals, I hope to have an arm that's meant for everyone, every woman, every man who wants to
mm.
better understand what is going on. Like, even just explaining,
Yeah.
like, here's what happens when you get your period. Like, these are the days at which your estrogen's going up. This is when it comes down. This is why you feel what you feel. Like,
It's
wouldn't that be nice for
ridiculous
us all
that
to
that's
know?
not just available. I mean, yeah. I mean, for
Right?
some, yes, that needs to be more available. Yeah, I guess you
Right?
could Google some stuff, but to be able to understand it is
Yeah.
something else.
Yes, exactly. Or just to say, like, this is what's going on. I think I love what I do, and I guess over the past year was starting to feel a little frustrated, like, "Well, I'm only one person, I can only treat this many people."
Mhm.
But, like, there's so many women who need help, like, how can I spread the
Mhm.
knowledge
Mhm.
somehow, and this is the
Mhm.
way I've come up with to try
Mhm.
to do that, and so I'm really excited about it because
Mhm.
I just love talking about this stuff, and I think it's so needed.
It is.
Yeah, so I'm really excited.
Yeah. That's great. I'm really glad that you're doing that. I think it takes all of us, all avenues, what your passion is, you like,
Just gotta
scream
go
it from the
for it.
mountaintops.
Yeah.
Yes, yeah. because we do need it in all avenues of meaning, like we need to learn about it wherever we can, but it needs to be
Right.
taught in different ways. And
Right.
yeah, anyhow, it's
Right.
fantastic.
Yeah, and that's another reason why I'm trying to figure out Instagram because I
Hmm.
also realized, like, all my patients come to me saying, like, "Well, I saw this on Instagram or I saw this on TikTok," and I'm like, "None
Hmm.
of this is right. Who are these people? Like, how do I
Right.
infiltrate
Yeah,
the
yeah, yeah.
algorithm to say,
Right.
like, no, this is what's going on, guys. Like, this
Right.
is it. Like, how do we
That's
get it
so
to the masses?"
that's so
You
important.
know, because access to care, as you know, is a tricky part of all
It
of
is.
this, so
It
it's
really is.
fun to find creative ways, like this
Hmm.
podcast, like other
Hmm.
little things to get the word out.
Well, thank you so much for coming on and sharing all of this. It's so much information. And so if for people who are listening, I'm sure we'll want to go back and like listen
Yeah,
to parts of it and all of that because because it's also so needed.
yeah.
This kind of stuff, just like share it widely
Yes.
as much as you can. So anyways, thank you for coming on and sharing all of
Thank
this with us
you.
today.
Thank you so much for having me anytime.
You can connect with Dr. Fury on social media at Dr. Katrina Fury, and you can also go to her website, soundpsychiatry.com. You can find out more about her practice and the online courses that she's offering. And I would like to also invite you all that if you haven't yet followed or subscribed to the Mom and Mind podcast, it is a free resource. I really, really welcome you to come follow so that you can get all of these episodes downloaded directly to you and they'll just show up. You'll be able to listen to them at your leisure. And also, if you have a moment to leave a review, whether it's just a star rating or a sentence or two about how the podcast has impacted you or how you found it supportive, these reviews are really important so that people who are looking for the support they need know that they're in the right place when they find the Mom and Mind podcast. I thank you so much for being with us today. Until next time.